A very good morning, students. A very fresh morning. So, welcome to the final session of physiology. With today, we will end the physiology, right? We'll finish the final topic. I think we are at something like renal system. So, we'll finish the final topic, that is CNS, neural system also. Neurology also will finish, that is neurophysiology, and we will get into the next subject, right? So previously we discussed everything, right? So this is actually old one, so leave it up. So I think yesterday we are about to discuss about clearance. Okay, so we will discuss about clearance. Okay, so clearance, what is clearance? Can anyone? What is clearance? The ability of a renal system or the ability of the kidney to excrete or filter a particular substance in a unit of time. So you call it as a clearance. The ability of the kidney or the ability of the renal system to clear a particular substance from the circulation in a given unit of time, that is called a clearance. You can denote clearance with a formula that is UV by P, right? Now just think one thing, actually, if only filtration occurs, that means if only filtration occurs, what is meant by this statement? That means there is no secretion and there is no reabsorption, right? Then there is no secretion and there is no reabsorption. Just think like that. If only filtration occurs, then it will be something like clearance is equal to glomerular filtration rate. For example, I will give you an example also. It is something like inulin clearance, which is used for glomerular filtration, GFR, glomerular filtration rate estimation, right? We use inulin, right? We use inulin for the estimation of GFR. So if only filtration occurs, that means there is no occurrence of secretion or reabsorption, then what condition applies is clearance is equal to glomerular filtration rate. For example, in case of a inulin clearance, which is used for GFR estimation, right? Now if secretion also occurs with filtration, just think like that, secretion also occurs with filtration, then that implies there is a increased clearance, then that shows increased clearance. The so-called value that we get is there is a increase in the clearance, right? That implies clearance is more than GFR. For example, for this also we have an example, that is creatinine clearance, which is 130, sorry, it's not minutes, 130 per minute, right? So that is why, because in creatinine only secretion and filtration occur, right? So if secretion also occurs with filtration, that implies it shows there is an increase in clearance. So that gives a value of increase in clearance. Now it is secretion and filtered both. The creatinine is secreted and filtered both, but little secretion will occur. Hence the clearance is close to GFR but not equal to GFR. It is almost close to GFR. So the most accurate, this is important, most accurate component for GFR is, remember, it is inulin, right? Now but remember one thing, but the most used, it's not accurate, but the most used for GFR estimation is, it is on and always creatinine. You got it? Always remember, the most accurate for GFR estimation is inulin only. But if the examiner asks what is the most used, he is not asking the most accurate one. He is asking the most used practically. In practicality, what we use mostly, that is creatinine content only. We use the creatinine estimation only, which gives the GFR. Okay. Now the full secretion, that implies if there is a full secretion, that means there is a 100% clearance of plasma. 100% clearance of plasma, that implies that clearance is equal to plasma flow. Okay. For example, for this condition, the example is para-aminohippuric acid. Para-aminohippuric acid, which is used for the estimation of renal plasma flow. You got it? Renal plasma flow. For example, if the full secretion occur, if the full secretion of the substance occur, then there will be a 100% clearance from the plasma. So that implies there will be a condition, that is the clearance is equal to renal plasma flow. For example, the para-aminohippuric acid, which is used for the estimation of RPF, that is renal plasma flow. You understand or not? See, very simple statements, no need to confuse. You just remember these two statements. These are very important, and these give the concept for NEET PG more than INICET. Okay. See, some of the students are asking, sir, why you are bringing NEET PG in between the INICET? Guys, if you attempt INICET, it doesn't mean that you will only attempt INICET, no. Obviously, you will attempt NEET PG also. Even though, if you still want to secure a seat in a central institute, but still obviously you will have an interest for attempting NEET PG also. Most of the students, 70% of the students who attempt INICET will obviously attempt NEET PG also. So why you are getting confused? What is the problem in learning these things? There is no problem now. Your time will not get wasted. I am not saying some sort of things regarding Sunny Leon here, right? I am saying about NEET PG only. These are important for NEET PG. See, nowadays NEET PG, INICET, both of these exams, they don't differ much. Almost they came to a equal standard levels. You get NEET PG questions as equal standards as the central institute examinations. But why the government is keeping two exams, I don't know. Maybe INICET has even more cutting edge questions, but I did not see that much of cutting edge questions in INICET. Yes, they are straight questions, simple questions, but the only thing that differs from one student to another student is, you know, that the hard questions that you get from medicine, and if it's something like, you know, you from pathology, yes, even pathology also you get some hard questions. And you take, if you ask me, SPM and one more subject. Wait, I just forgot it. What's that another subject? No, not anatomy. Anatomy, physiology, biochemistry. I think it's an anatomy. Yeah, it's anatomy only. So just okay. Yeah, some subject, but these three subjects, most of the students, nearly something like 96% differ. 96% students differ in their ranks depending on these three subjects only: medicine, patho, SPM. Most of the 96% students do mistakes in these three subjects only. The rest of the 4% of the students who secure seat in the INICET. See, 4% means, don't think like if 1 lakh people wrote, in that 4% I am no, I am not saying like, I am just giving a random figure. Means the lowest number of percentage of people are only attempting utmost accuracy in SPM, medicine, patho, which make them to secure seat in AIIMS or any other central institute. So everyone will secure the minimum marks in AIIMS, but the difference that makes is these 3 or 4 subjects which are actually there. But no problem, your wise doctor sir is here, and I will make sure that you clear each and every subject with flying colors. Okay, Without making any delay, we'll just get into the next statement. Right now, in this clearance, we have one more thing, that is, see, previously we discussed about only filtration, with secretion, full secretion. Now if with filtration, with secretion, if reabsorption also takes place, then the clearance will be less than GFR. Right? Example, urea clearance is equal to 70 to 90 milliliters per minute. Right? So if 100% reabsorption takes place, for example, if 100% reabsorption takes place, that implies, is there any amount of substance present in the urine? 100% reabsorption, I am saying 100% reabsorption. That means, for example, there is a substance that is named X. If there is a X substance which is actually present in the circulation for nearly 20 milligrams. Now if this 20 milligrams present in the urine is reabsorbed into blood again, now will there any percentage of the X, will it excrete through urine? No, there will be 0% excretion, because all the 20 mg present in the urine is completely reabsorbed. That means 100% reabsorption. So 0% is cleared in the urine. That means the clearance is 0. So which substance will have the clearance value of 0? Example, glucose. You don't see much, I am not saying 0, but you don't see much glucose, which is considerable amount in urine. If you see a considerable amount of glucose in urine, that implies what it implies? That person is suffering from diabetes. So if you see considerable amount of glucose in urine, something like 160 milligrams or 140 milligrams or 135 milligrams, that means that person is suffering from diabetes. Right? So clearance is 0 regarding glucose as well as amino acids. Got it? Got this right? Okay. So we explained all the conditions. Now we will discuss some of the points even better. Now the glucose is actually 100% absorbed. Remember these things: glucose, amino acids, these all are 100% absorbed. Don't think like glucose will have any clearance. Its clearance is 0 because it's 100% absorbed. So you will not see any secretion of glucose in the urine. Ultimately it will have a clearance of 0. Now it is reabsorbed, 100% reabsorbed, but where? In the proximal convoluted tubule. By which transporter? SGLT2 transporter present with the apical, at the apical, and one more transporter is GLUT2, GLUT2 transporter in the basal. You understand? Well, some of the people still did not understand. See, this is lumen. Now this is a PCT cell, that is proximal convoluted tubule endothelial cell. Okay. Now at the apical portion, wait, I will just draw with another color, otherwise you will ask me, sir, what is that one, sir? See, at the apical portion you have SGLT2 transporter which reabsorbs the glucose, and at the base you have GLUT2 GLUT2 transporter which reabsorbs the glucose. Okay. Now if you ask me, what is meant by Tm of glucose? Some of the students ask me, sir, what is meant by Tm of glucose? See, Tm of glucose means the maximum transport of glucose, or you can also define it like transport maximum of glucose. Now what is meant by that? It is nothing but the maximum glucose that can be reabsorbed per minute in tubule. That is called as TMG. It is defined with the value called TMG, that is the maximum amount of glucose that can be reabsorbed in the tubules per minute. Maximum glucose that can be reabsorbed per minute in the tubules. Now what is the value of TMG? The value of TMG is 375 milligrams per minute. So 375 milligrams of glucose is reabsorbed from the tubules per minute. That is called a TMG value. That is transport max of glucose. Now there is one more component called FL. What is meant by FL? Filtered load. Filtered load. What is filtered load? It is the amount of substance filtered per minute. It is the amount of substance filtered per minute. Amount of substance filtered per minute. That is called a filtered load. Now you can even count it like GFR multiplies plasma concentration. Right? Now if FL, the filtered load, is greater than TMG, that is transport of maximum glucose, right? So that implies, you understood or not? If the filtered load is greater than TMG, that implies, can anyone? That implies the so-called glucose is not 100% reabsorbed. Arey, what is that much confusion? What is that much of confusion in that statement? It's very simple, right? If the filtered load is more than TMG, that implies there is a secretion of some amount of glucose through the urine. That implies there is glycosuria. That means 100% of the glucose is not being reabsorbed. So there should be some sort of problem with the kidney, or you should be suffering from the diabetes, right? So obviously not 100% of the reabsorption takes place. That condition we define it as glycosuria. So there is a excretion of glucose in the urine. Okay, so glycosuria occurs. Now we will discuss some conditions here. For example, there is a increased filtered load. Increased filtered load. So simple theme is high load causes glycosuria. In which condition you see this? You see this rule. You see this rule in diabetes mellitus. In diabetes mellitus, this one happens. If there is a high load, then obviously glycosuria occurs. Now if the TMG is less, that means TMG is less. TMG is less. The TMG is less. Wait. If the TMG is less, that means only some amount of the glucose is being reabsorbed. Only less reabsorption of glucose is being taken place. That implies there is a tubular secretion. So this is seen in Fanconi's syndrome. Fanconi's syndrome. And you can also see this one in another condition, that is acute tubular necrosis. Right? If the TMG is less, that means there is a less reabsorption, less amount of reabsorption is being taken place. So this is observed in Fanconi's syndrome and acute tubular necrosis. Now we will discuss something about a very important segment, that is JG apparatus, means juxtaglomerular apparatus. Now the JG apparatus actually consists of three types of cells. Now what are those cells? The first one is Lassus cells. The second one is JG cells in afferent arterioles. JG cells in afferent arterioles, juxtaglomerular cells in afferent arterioles, and third types of cells are nothing but macula densa cells in DCT. Macula densa cells in DCT, distal convoluted tubule, and also ascending loop macula densa cell in DCT. Okay, just leave this about macula densa cells. Okay, now if you want me to draw the thing, then I will draw. If you don't want, then I will leave. You want me to draw or not? Just one word. You want me to draw or not? You want me to draw? Okay, fine. Okay, fine. No problem. I will draw here. Okay. Now, you see this? So these are the cells. See, my drawing is worst, I know that, but please just focus on the concept only, don't focus on the drawing. So these are the cells, remember. I'll just drop the nucleus also. So these are the cells. Now this is a, I'll draw with red. Now this is a efferent arteriole. This is a efferent arteriole. Say that it comes like this, and you can also see that here you come afferent arteriole. This is afferent arteriole, this is efferent arteriole. Right now, if you observe these things, here you have something called juxtaglomerular cells. These are juxtaglomerular cells. You have here also, right? So these are juxtaglomerular cells, nothing but juxtaglomerular cells, and these are supplied by renal nerve. You got it? Renal nerve. Now you have one more thing, that is what is this one? Anyone? See, there is no wasting of time, guys. Why are you saying like that? There is no wastage of time. See, everything is useful, right? Now this one, here you have something called macula densa cells. Macula densa cells which line the DCT. Macula densa cells which line the DCT, lining the DCT. You got it? Now once we will label everything. So this is efferent arteriole, and this is afferent arteriole, afferent arteriole, and this one is renal nerve. This one is renal nerve, and this one here is, these cells are juxtaglomerular cells. Juxtaglomerular cells, right? Now this one is Bowman's capsule. You already know this is Bowman's space. This is Bowman's capsule. This is proximal convoluted tubule, PCT, right? So, and this one is finally macula densa cells lining the DCT. Okay. Now this is all about your juxtaglomerular apparatus. Now, if you discuss about some more important things, you come to Lassus cells, the first type of cells, that is Lassus cells. These Lassus cells are nothing but mesangial cells which act as macrophages, And the second type of cells is juxtaglomerular cells. Juxtaglomerular cells in afferent arteriole. Juxtaglomerular cells in afferent arteriole, what they can do is they can sense the renal blood flow. Juxtaglomerular cells in afferent arteriole, they can sense the renal blood flow, and what they do is they release renin. And what this renin do? Actually, if there is a poor blood flow, what it do is, obviously there will be a causage of shock, decrease in blood pressure, and a sympathetic system, obviously it gets activated, right? And there is a decrease in sodium, etc., happen. Now, and release renin if poor flow, right? Now what it does is it activates the RAS pathway. What does RAS causes, right? What are the causes of RAS? If there is a vasoconstriction, thirst. So RAS, what it does is it causes vasoconstriction, thirst, increase in antidiuretic hormone, and increase in aldosterone. Now these all things lead to increase in sodium, increase in volume, further again bringing the BP to normal state. Now see, the mechanism is very simple. For example, if there is a decrease in the renal blood flow, if there is a poor renal blood flow, what happens is it leads to release of renin. These cells, these juxtaglomerular cells, sense the renal blood flow and they release the renin. This renin ultimately acts the RAS pathway, renin angiotensin pathway, right? So RAS pathway, RAS system, this RAS, what it does is it produces vasoconstriction, increases the thirst, increases the ADA, increases the ADH. ADH means antidiuretic hormone, vasopressin. It helps in selective reabsorption of the water. So there is an increased reabsorption of water which leads to increase in the volume of the body fluid, and there is also increase in aldosterone. Okay, so these all things ultimately bring the BP to normal again. You got it? You got it or not? And the third type of cell, that is macula densa cell. This cell, what it does is, in ascending loop for glomerular filtration regulation, they help. These macula densa cells in distal convoluted tubule and ascending loop, they help in GFR regulation. Simply I will write, right? These things, they help in GFR regulation. Where? In which part? In DCT and ascending loop. Now this sort of GFR regulation by the macular denser cells in DCT and ascending loop, this phenomenon is called tubuloglomerular feedback. Tubuloglomerular feedback. Now how it occurs? They first sense the glomerular filtration rate by sodium chloride other levels in the tubular fluid. What it does is, these macular denser cells, they sense the sodium chloride levels in the glomerular filtration rate. They simply sense the glomerular filtration rate by sensing the sodium chloride levels in the fluid. Further, what they do is they correct the GFR by intraglomerular mesangial cells, contractile cells around the glomerulus. You understand or not? You understand or not? Did not understand. Okay. See, I will tell you once again. Simply remember, macular denser cells, they just simply correct the GFR and bring to normal state. How they bring the GFR to normal state is by, just simply remember this, they simply act on intraglomerular mesangial cells. Intraglomerular mesangial cells, which are contractile cells. These contractile cells, that is intraglomerular mesangial cells, present around the glomerulus. Around the glomerulus. Now, if these cells relax, then obviously the GFR increases. If the cells contract, then obviously the GFR decreases. In this way, the macular denser cells regulates the GFR, glomerular filtration rate. Now you got my point? Okay. Now we will finally discuss about efferent arterial constriction. Efferent arterial constriction by AT2. Right? So what it does is, it decreases the renal blood flow but it simply decreases the renal blood flow, but the blood accumulate in the glomerulus, right? It simply decreases the renal blood flow, but what happens is, after this the blood accumulates in the glomerulus. The blood accumulates in the glomerulus. Now, if the blood accumulates in the glomerulus, what will happen? Anyone? Ultimately, it leads to increased hydrostatic pressure. And also, it also increases GFR. So, what is that? You understand? Efferent arteriole simply increase the GFR. Okay. Now, if the afferent arteriole, afferent arteriole dilates, what will happen? For example, if the dilation occurs due to dopamine, for example, there is a dilation of afferent arteriole due to action of dopamine, then what happens is, there will be an increase in renal blood flow, further leading to increase in hydrostatic pressure, further leading to increase in GFR. Okay? Understood or not? Okay, thank you. Now finally we came to the end session of the physiology subject, that is neurology or neurophysiology. neurophysiology, right? Just 1 minute. Okay guys, so welcome to neurophysiology. We'll just start the session. Neurophysiology. We'll just finish as fast as we can. Okay. Now this is the neurophysiology. There's something called central nervous system. It consists of, or is accompanied, or it's surprised with, it's packed with neurons and glial cells. These are two types of cells present in the central nervous system mainly, right? If it comes to neuron, there are 100 billion neurons in your body. 100 billion neurons in your body. And remember one thing, no neurons will form after birth, except where hippocampus. Now if you come to the glial cells, what about the glial cells? See, glial cells, they are actually more in numbers and they can form new cells. For example, we heard about some tumors, right? What are those tumors? Gliosis, glioma, all these things. Gliosis, glioma, etc. Okay, these are all tumors. That implies the glial cells can reproduce even in the adult stage also. That means in the aged people also, these can form new cells which are converted into tumors. Now what are the types of glial cells? That is important. What are the types of glial cells? What are the types of glial cells? Now the first one is microglial cells. Microglial cells. They are actually the CNS macrophages which are for phagocytosis. These are actually the CNS macrophages which are for phagocytosis. Now the second one is oligodendrocytes. What are these oligodendrocytes? They actually make the myelin sheath. They actually make the myelin sheath in CNS. But who makes the myelin sheath in PNS? Myelin sheath in PNS is made by Schwann cell. Remember, the myelin sheath in PNS is made by Schwann cell, whereas the myelin sheath in CNS is made by who? Oligodendrocyte, Schwann cell. Okay. Now, what are the third type one? That is ependymal cells. So, ependymal cells. What are ependymal cells? Ependymal cells are nothing but they are actually the lining cells of ventricles. They are actually, I can't see the cursor. They are actually the lining cells of ventricles. Lining cells of ventricles. Now the fourth one is astrocytes. Astrocytes. What is the use of these astrocytes? They are nothing but supporting cells to neurons, and they help in the blood-brain barrier forming. That is called tight junctions. Blood-brain barrier forming, that is tight junctions. The forming of BBB by astrocytes, which act as tight junctions. Okay. Now that is all about the types of glial cells. Now coming to the next important thing, that is CSF. What is CSF? Cerebrospinal fluid. Now daily 150 ml of CSF is produced? No. The total volume of CSF is actually 150 ml. Now daily there will be a production of 500 ml per day, or you can also say it like 20 ml per hour. Now where does the CSF secreted? The CSF is secreted by choroid plexus. Choroid plexus. Now one more important thing is, where does the absorption takes place? Absorption takes place at arachnoid villi. Arachnoid villi. Okay. Now what is the normal pressure observed here? Normal pressure observed here is 50 to 130 mmHg or 5 to 10 mmHg. Okay. Now what are the functions of CNS? What are the functions of CNS? What are the functions of CNS? The first one is nutrition. Second one is waste removal. See, nutrition with what substances? Oxygen, amino acids, and glucose, etc. Now also waste removal. Okay, and maintaining the temperature, pH. See, these all are the functions of CSF. Remember, pH, osmolarity, etc. Temperature, pH, osmolarity, etc. And it also acts as shock absorber. Now CSF is actually similar to plasma. Remember, CSF is actually similar to plasma, but with a lower concentration. Because the glucose is 60%, and there will be a lower concentration except PCO2, HCO3, that is bicarbonate, magnesium chloride, which are actually partial pressure of carbon dioxide, carbonate, magnesium chloride. These components are actually present in high concentration in CSF. Now coming to the neuron anatomy, very important, the anatomy of a neuron. Sometimes even these type of silly questions might come in your NEET PG. I won't expect in INICET, but this will be in your NEET PG. Very simple, we will draw one fast neuron. Okay, now this is a neuron. Now this is a neuron. This much of nucleus will not be. Yes, this is a perfect nucleus. Okay, this is nucleus and this is soma. That is soma. Just 1 minute.